Welcome to Interdisciplinary Case Miles, a podcast where real runner stories meet clinical expertise. We discuss real cases that are anything from weekend warriors all the way to elite athletes, while using our evidence-informed approach.
I'm Dr. Sara Raiser, a running medicine physician focusing on helping runners prevent and recover from running-related injuries while optimizing health and performance.
I'm Kelsey Pontius, a sports dietitian helping runners to fuel smarter, recover better, and help avoid the risk of injury so that they can meet their goals.
And I'm Dr. Mihevc Edwards. I'm a physical therapist and orthopedic specialist, and I've been treating for runners for over 15 years. And what I do is help them get back stronger and better. Hi, everybody. Welcome back to Interdisciplinary Case Miles. We are so excited to be here. My name is Kate, and how are you guys doing today?
We're doing great. Very boisterous over here.
We've had a few great conversations offline already that we broke out in full laughter mode and had to control ourselves, but that's okay. I wanted to start today and just kind of ask each of you, what have you been working on lately? So I think we don't really talk about what we do on a regular basis on this podcast. And I know you guys have been working on some good stuff. I've been working on some good stuff. So Kelsey, why don't you start and tell us one of your projects you've been working on?
I've been working on my second ebook. It's Miles and Meals with Meteor. A mouthful. I don't know why I did that to myself, but I'm putting finishing touches on it and I'm really excited. I honestly got this idea 3 or 4 weeks ago. My hamstring might have flared up and I needed, something to distract me. And so I told one of the girls that works with me, I'm like, let's write a book. And she's like, when do we want to be done? And I said, December 15th. And she probably panicked a little bit, but yeah, I wanted it to have like 4 recipes for like 6 chapters. And now it has 8 recipes and like 10 chapters and like 8 recipes. So it's getting lengthy, kind of like we do on the podcast.
That's okay. That's pretty awesome. How about you, Sarah?
I'm excited.
Oh, that's awesome. And actually, I was going to say, Kelsey, I have had a couple of folks this last week who were very appreciative that I suggested your ebook to them. So yeah, it's reaching far and wide, which I think is awesome. So a couple of things. I was actually just talking to a medical student who's interested in writing a review on a female specific topic, which I thought was really cool. And she reached out to me. So a couple of things that we were talking about, a lot of the work that I do, I'm trying to do a lot of outreach. So a couple of different levels. One of them is we're doing some high school runner education programming, and we're actually meeting in a couple of weeks to debrief on our first inaugural session this past August. And then we're also doing National Grand Rounds, which I've taken a little bit of a respite from it these last few months, but hoping to get back to a strong monthly showing in these next months. And just so you know, if you're interested, it's totally free. You can join us. I just need an email to get you listed. But we also have playbacks available on the UVA Runners Clinic website as well. So definitely check that out if you're interested. But yeah, we've always got our toes in a lot of different ponds here. So Kate, what are you doing?
Well, I'm resting.
Really?
Nobody believes me. I actually just got back from the running event, TRE, which was my first time there. It's a running trade show, and it was great. I spoke while I was there, and I actually talked about how running specialty and brands can collaborate with healthcare providers. And so it was really cool. It was a packed room, lots of questions, and being there really highlighted how much that relationship is lacking, that there were hardly any medical providers at this entire conference of thousands and thousands of people that loved running and worked in the running industry. And it really opened my eyes up about how much work we need to do to bridge that gap. So I'm looking forward to continuing to do work in that area and kind of bridging that gap so that we can really meet runners where they are, rather than, feeling like we're on a total disconnect or preaching to runners. I don't ever want to do that because we're part of that group. I just want to make sure that we can reach them in the best ways possible. So that's what I did this week. It was super fun. And I got some free.
I was not resting.
I know it wasn't, but now I am. Now I'm resting.
Hey, I saw that you were on runs yourself.
Yeah, I did go for a run. I have been running 1 or 2 times a week secretly, and I can only go. There's a lot of rules. Like I can only go with somebody. It has to be slow. There has to be some walking, all of that because of my heart thing. If people don't know, my rare genetic heart disease. But it was the first group run I'd done in 10 years, and it was really hard for me because I used to be at the front, and I was super competitive. But I was in the back, and I did walk run, and I loved it, and I had a great person with me, so that was cool.
The only thing that I thought was, wow, Kate already, she went on one run and she has all these runner friends. That's what I took away from seeing it.
That's funny. All right, well let's jump into this podcast today. So I'm actually really excited about this podcast and this case because it's something that I've been talking about lately and I've actually seen in the clinic. But this case is a 46-year-old woman. She's training for a 10K and wants to kind of get to the half marathon. She's increased her training lately in the last 3 weeks or so, and she's doing strength training, but it's intermittent, like maybe once a week, twice a week at best. Her pain is located on the left lateral hip. It's stiff and achy, and she has difficulty getting in and out of the car, sitting cross-legged. She has pain sleeping on that left side, and she has pain going up and down stairs. There's also some discomfort when she's running or anytime she's kind of on one leg. But there's no sharp pain, no pain with hopping, anything like that. There is really nothing that's helping her at this point. She's also had trouble sleeping lately. She says she's a bit moody and she's got some GI disturbances. So this is something that I diagnosed with a glute tendinopathy. So we're going to talk about glute tendinopathy in a woman that is in that kind of menopausal transition. So I think we've got a lot to talk about today. I think that let's have Kelsey start and give us a little bit of information about what she would start or how she would start a conversation with this patient.
Yeah, I think that it's hard to ignore what phase of life she's in and some of the biological changes that she could be going through at this phase of her life. And so I'll kind of hop in. I think that you'll do more justice talking about the changes in the musculoskeletal system, but I'll kind of hop on, if that's okay, talking about like some of the GI disturbances piece, because I feel that is something that's not common knowledge. And it is related to some hormone shifts and hormones just being suppressed relative to earlier phases of life. So less estrogen, less progesterone is going to decrease the amount of motility in the gut. And so this is going to affect the way that water is reabsorbed in the gut. And so oftentimes this manifests into like constipation, gas, and bloating. That's obviously very, very uncomfortable, not to mention if it's accompanied to like any other body changes that this individual is going or is experiencing. And then changes in the diversity and just the composition of the gut microbiome is different. And so that's going to affect things like nutrient absorption. And we know micronutrients are so responsible for how the body can recover and building new tissues and stuff like that. There's reduced stomach acid and bile, just like hormones are being suppressed. Other digestive properties are starting to slow down a little bit. So stomach acid, bile, not so much at 46, but just like changes. And then a big thing that we have a lot of research around is actually a change in something called intrinsic factor, which is connected to how we absorb B12. And B12 is a coenzyme for so many metabolic processes that are going to contribute to how tissues repair. So there's so much to be talked about. This is just the GI tract. I could talk about sleep. I could talk about so many.
I love this when you get like this.
Yeah. Yeah. I think something that's important to say too about this age that I'm noticing is if there is body changes, because spoiler alert, bodies are meant to change. We are not meant to stay the same. Then a lot of times there's resistance and there's a lot of marketing with this demographic, especially to women, that we're supposed to avoid body changes and that weight is connected to health, and that's simply not the case. Those are two very different things. And so a lot of times I see underfueling because all of a sudden our hormones have started to shift and we can no longer eat carbohydrates, or metabolism has slowed and all of these variables. And all of a sudden we go from eating normally to we can't eat a thing. And that's just going to slow down the healing process. And in my opinion, I think this is a timeline where the body actually needs more support due to these physiological changes and not less with nutrition. And so I could go on forever about this, but that's kind of the trends that I see is like, there's a lot of information around protein. There's a lot of information around fiber, but now that's the only thing we can focus on. We have to eat all this protein and then we don't have enough room for carbohydrates, which we still need. And so it's a lot of looking for the silver bullet instead of realizing there's a lot of things going on and that just because, we're a couple years older, our nutrition needs they shift, but not so dramatically that we're stopping all of our fueling.
So I do want to say that prior to this recording, we had a pretty in-depth, so Kelsey and I were texting back and forth, and we had a pretty in-depth conversation about how there's a lot of media out there right now and how everything is black and white for this population. And it's too black and white. And as an expert, and as we're all experts in what we do, there is never a black and white answer. And it has to be said, like I just have been wanting to scream about this and all of the things that I've seen in the media there's not a black and white answer. Every human is individual, and the way that we are injured and the way that we recover from injury and the way that we move about in the world and how we train, there are so many individual factors. That's why running injuries are multifactorial. That's why there is never one answer. So people are really looking for one answer to solve a problem, and it's just not that easy. And I really felt like it was important that we said that because it's so true. Do you see that a lot, Sara, when people come into your office?
Well, what I was going to say is that's what drove this whole podcast, right?
Yeah.
I mean, is recognizing that this is not black and white. This is not reading a textbook. This is in some ways reading the textbook and then unlearning the textbook because this is the art of medicine, not science in a lot of ways. One of the phrases I thought of while you were talking, Kelsey, was I tell people their body is different every single day. My kiddo keeps asking me about death and dying. We're in that phase right now, having these conversations. And I'm like, well, everyone's getting older every day, right? Our body is literally different every morning that we wake up. But you have adolescence and menopause that you have bigger changes that are happening during those time frames, but I try to give people a little bit more benefit of the doubt or have them give themselves more of that benefit of the doubt during those time frames because there's so much going on. But I totally agree. I mean, I think this is part of the direction that medicine is going is we are not a 5 to 10 minute visit. There's a lot to go through, and a lot of this is empowering people and educating and giving insight so they can understand their bodies better.
Yeah, totally. And I think sometimes with these changes, oftentimes, at least what I hear in my scope is women feeling like because they're noticing these changes, especially changes to body composition, they feel like they've failed. And not so much that this is a normal biological process and they haven't done anything wrong. Yes, we need to shift how we do things and focus on certain areas of the nutrition, but they have not done anything wrong and they have not failed. And because their body's changing doesn't mean that, they have it all wrong.
Let's work with the body, not against the body, right?
That's exactly right.
Very different way to reframe it, I think.
I'm going to circle back a little bit and pull you in on this, Sara, about glute tendinopathy, because I think everything we're saying is so important and it's exactly how we would treat a patient. But I also want to kind of stay in the line of sight here. And so one of the things that often happens with a glute tendinopathy, especially in this age group, is that it's misdiagnosed as bursitis. And I would love for you to kind of dive into that, Sara.
Yeah, so I think bursitis has certainly gotten to be a diagnosis that is used more often than not, and in some ways kind of simplifies the diagnosis a little bit because bursitis suggests that you have this little bursa or sac that usually doesn't have fluid in it, and now it has fluid, and that's causing all the pain. And how do we get rid of that? Well, the answer is usually there's either something going on underneath all of that. So when we're talking about the glute tendons, we're talking about the hip joint. So there can be pathology in the hip joint. So this could be arthritis, this could be a labral tear, some micro instability, you name it. it. It could also be the back. So your L5 nerve root especially is going to innervate this particular area. And if you've got some irritation or even just stiffness and neural tension coming from the back, that can also stimulate glute pain and contribute to this as well. So in a lot of ways, this is a really complex type of workup in some ways, especially for someone who's really active and doing a lot of running and wanting to increase their running. So I'm sure Kate is salivating here of like all the biomechanical things that we can work on, right? Yeah. But a couple things that I was thinking about too. So a couple things that you've both kind of touched on already in terms of like the fatigue piece and asking about like musculoskeletal aches and pains and, are you perimenopause? Have your menstrual cycle started changing? Have you noticed changes in your body? And then the restricted food intake is just huge. And so I look forward to Kelsey talking more about this, but I see it so commonly. And not to get too sidetracked, but I always think about this one patient who had comminuted calcaneal stress fractures in both feet after a Europe trip. And when she came back, it's like, I'm pretty concerned you have osteoporosis. And also, like, let's take a look at your labs and get you with a dietitian. It turned out she was restricting her food intake just wildly because she was so worried about her thyroid slowing down and the perimenopausal changes. And we made really wild changes for her, which was life-changing. But I always think about that when I think about the perimenopausal changes and how much it can impact us. And also just this validation of women going through this phase. This is normal. It can be scary. There are so many feelings that go with it. But then how do we address it? And again, kind of embrace it and understand what's happening to be able to make the most of it. So going back to the anatomical piece, one of the first things I look at once a patient has made it to me, usually they've already been to a PT or, a couple other stops along the way. I get some x-rays. So, is there clearly some arthritis going on in the hip? Because if there is, oftentimes that's going to be the first thing I kind of explore is there arthritis? Is there something going on from the joint perspective, even if it doesn't seem to be directly causing pain? Because the hip joint can cause pain patterns in so many different directions. And I very frequently see this lateral hip pain with it. They can potentially have bursitis, but usually I see it's a result of a tear in the glute tendon. So investigating what their tendon looks like potentially. This doesn't have to be the whole kit and caboodle with tons of imaging. So oftentimes this is a stepwise process. We might just get some x-rays and then do some education and start with some physical therapy and see where we get from there. It might also be a dietitian referral. And if things aren't working, sometimes we'll go down kind of a stepwise path of trying to figure out where the main pain generator is with some injections, whether steroids or just a lidocaine and numbing medicine, to figure out if we numb it up, what pain does that take away? Is that, the primary spot that's bothering folks? So it ends up being a relatively in-depth workup in kind of stepwise fashion. And how much we do when I first see them depends on how many providers they've seen and how absolutely tired of this they are. There are a number of ways to treat tendons. And I always tell patients that our musculoskeletal medicine has kind of flipped ends of the spectrum. So we used to be anti-inflammatory everything. And now we realize that actually inflammation does a lot of good. So being able to actually cause some inflammation sometimes can actually stimulate some of that healing process. So this is where we start getting away from doing lots of NSAIDs and lots of steroids. There can be a place for it, and I do occasionally use them, but really emphasizing the importance of actually stimulating that healing process and doing that with some physical therapy, which the strengthening piece is also very important for getting the tendons to stimulate their healing process.
That's great. Thanks, Sarah. So I'm going to talk a little bit about hormones actually, and then the physical therapy component of this. And so one thing I would like to mention is that there are a lot of different pain patterns when it comes to the hips. But with a glute tendinopathy, it's very specific and it's very local on that lateral part of the hip. So you're not going to get groin pain. You're not going to get a lot of the other signs and symptoms of other joint-related issues if it's just glute tendinopathy. However, estrogen actually helps with joint lubrication. And when we have a drop in estrogen, our joints aren't as lubricated. So then things can start happening in the joints. When the joints are affected, the tendons and the muscles have to work harder. So a lot of times you'll have like a glute tendinopathy with a hip joint issue because of this interaction. The other thing is that with a drop in estrogen, what happens is that it makes it difficult for the tendon itself to repair itself very well. So what happens is the tendon becomes more stiff and less elastic. Tendons are made up of collagen. There's two types of collagen, collagen 1 and collagen type 2. What happens during this period of time is there's less collagen 1 or type 1 that's created because of this drop in estrogen. And when you have that less of that collagen or number 1, I don't know why I can't just say type 1. That's what we call it. But collagen type 1, then you're also at higher risk for injury. So there are a couple of things that are happening with this drop in estrogen when it comes to the musculoskeletal system, which puts us at a higher risk for a tendinopathy in general. But what we're finding is women in this menopause transition are highly likely or more likely than men to have a glute tendinopathy. So I just wanted to outline that change in the hormonal profile. There are other aspects, but when it comes to the musculoskeletal system, those are things that we're looking at. So from a PT standpoint, the other thing we want to think about too is you mentioned corticosteroids, and a lot of the research for the last several years, but then even in this paper I read recently, which is a 2005 paper, it said that corticosteroids injection into a glute tendon, it actually doesn't help any more than the wait and see effect or other treatments. And so it's one of those things that's what the research is showing. That's what we see in practice. But there are times, like you said, Sarah, where it might be beneficial. So it's not a don't ever do it kind of thing, but we're definitely leaning towards we don't need to do that as much. So from a PT standpoint, things that I would be looking at are definitely biomechanics, like you mentioned, Sarah, because it's my fave. So I'll be looking at how this person is running and how they're walking. Do they have a lot of hip drop? Is their leg coming or their femur coming into adduction? What's happening to put stress on that outside of the hip so that it's loading that tendon more and creating more breakdown? So a lot of hip drop, a lot of adduction is really part of what we're looking for there. And even hip extension. If you're not extending your hip as well, then you have to get that motion somewhere else. It could be your lumbar spine, or you could be rotating and not controlling rotation of that limb very well. So that could create some issues there. And what I would want to know is this, I would send to someone like Sarah to find out if there is a tear or if it's a tendinopathy. And then for treatment of tendinopathy, it's the same in terms of what we would do: eccentric exercise, strengthening the pelvic girdle, doing single leg strength, making sure I would do blood flow restriction training. I would make sure that we give that area of the body as much support as possible from strengthening and a mobility standpoint so that it can move in the way that it needs to be running.
And I was going to add too, I like to ask pelvic floor questions for this, especially because so frequently this is in women and perimenopausal. And so there's a lot of pelvic floor changes that are happening then. And oftentimes at that point in their life, women may have had pregnancies. They may have experienced urinary incontinence, constipation, all these things that have effect on the pelvic floor. And I was actually chatting with a physical therapist about this morning, and it's like, patients are oftentimes kind of taken aback that you're asking them these questions, but then like, oh yeah, I can see how these things are related. And so being able to address the core piece, I think, is so important. Oh, and abdominal surgeries, that's another really big one, where they had a C-section years ago and never had any pelvic floor therapy since then. It's quite possible this abdominal's never turned on since that time. So making sure that we're addressing the historical part of it too.
Yeah, that's absolutely true. And the other piece, because of the changes in the hormonal profile around this period of life, if you had anything happen in your pelvic floor, well, if you had a baby postpartum, it may not have shown up. So sometimes you don't even get stress urinary incontinence after you've had a baby, but you get it in that perimenopause, menopause, or menopausal transition time because of the change in the hormonal panel. So it is something to think about. And I always ask about pelvic floor and always look at their breathing and see like, how is everything working? Is their deep core working? Because almost always there is a component of pelvic floor when we are talking about the hip. It doesn't matter if it's glute tendinopathy, if it's OA, or if it's a labrum or FAI or even back pain. There's usually some component of the pelvic floor, whether it's not firing enough or something I don't think we talk about is it's firing too much. It's which is
common in runners.
It's common in runners and women type A. I mean, I don't really know any of those kind of people, but whoever they are.
None of them are here for sure.
None of them are here. Okay. So Kelsey, you had mentioned earlier when you started talking about the nutrition piece that you could talk also about sleep and some other things. I'd love for you to dive into that piece a little bit.
Yeah, totally. I like to really understand. I think that's another thing that people with sleep are also looking for the magic bullet. Is it just the melatonin? Is it the valerian, like what is it? And so I like to understand like what is kind of the struggle with sleep. Is it falling asleep? Is it staying asleep? I think sleep is fascinating. And so I actually just love it to begin with. And so kind of get a good idea after I've done a nutrition assessment. Is there anything, any gaps in their nutrition or any patterns in nutrition that could be bleeding into their sleep quality? And then kind of see what their sleep hygiene is like, which I know isn't fun for anyone. And oftentimes people feel like it's too basic, but a lot of times I'm like, okay, let's do this for 2 weeks. Promise me for 2 weeks. We can look at things like even blue light can disrupt the melatonin, and melatonin is a hormone, and hormones work in a symphony. And so that's going to impact the other hormones, such as progesterone, which is that calm hormone that allows us to have good sleep quality. That's, that's being changed in bodies too. And so, yeah, I like to kind of just see like where they're struggling. Are there any gaps with their nutrition of not meeting their nutrition needs? What do we need to think about from a sleep hygiene component due to, just overall stimulation of the day? And then I would also like to add, this is always the demographic of women doing the most. Yes. And so like parents, career, trying to train, like all of these things, they're doing the most. And so, yeah, I tend to, while the evidence in the textbook answers, as Sara talked about, was for nutrition is they need more protein and they need more fiber. It's like, okay, yes. But some of these women that I work with, I'm like, they don't even take a lunch break because they're doing the most. I'm not going to tax them with counting their grams of protein during the day. I just can't do that.
Yeah.
So I've actually, looking for the low-hanging fruit is huge. So just talking to folks and figuring out what their daily life, if I find out they're not eating breakfast, great. I can easily make a big change. Let's eat breakfast. I don't care what it is. Just make sure you're getting something in, right? So making a couple small things and being hungry in the middle of the night can certainly affect your sleep too, as you know, Kelsey. So even talking about how those things are all connected. I always ask about sleep more specifically in terms of symptoms, and just kind of the targeted musculoskeletal conversation I have. But if people are having symptoms at night and they can't sleep because this is painful, that immediately changes what I'm going to do. So I'm much more likely to reach for an injection or try an NSAID or try something, because to me, that's pain out of control. And if that's affecting your sleep, your pain cycle is just getting worse. And so that's one of the first things that I'll treat is like daily pain with ADL. So your activities of daily living, and then sleep. And if we could do that first, get your head right? So that you're like functioning kind of on a normal daily basis. And then we start working on the rest of it. So I think kind of contextualizing where people are is so helpful. And I realize as you're talking, like, oh, I always ask about sleep, at least in that context. And sometimes I get more information from them too. Or people are like, well, I don't want to take medicine to help me sleep. I'm like, well, sometimes a little help can be useful initially to kind of get you a little oomph. And then we can get into like the CBT, the cognitive behavioral therapy, and those things are more in depth later, but let's just treat your pain and get you feeling more normal, quote unquote normal. Yeah.
And one of the things that I think happens with this population as well, and this is actually a lot of my friends too, is that now that there is all this information out there, all these research studies coming out, and things are changing all the time, and it's actually in the media. Women are being talked about in the media and the research. They're all trying to do everything that they've read about and that they've heard on the podcasts and that they've seen on whatever. And so one of the things I often do with this population, especially, if they're injured, which is why they're usually coming to me, is I'll say, okay, let's just stop. Let's just take a breath. You're doing way too much. And I think that the stress of you trying to be perfect and manage all of these things to get your fiber, get your protein, make sure you're walking 10,000 steps a day, wearing a weight vest, going and doing heavy weights 4 or 5 times a week. And like, I could make, the list goes on, like all the things, like the collagen and the whatever. So there's so many things that are happening and we're being fed. This brings it back to that conversation of we're individuals. And just because those are all the things that you're seeing in the media doesn't mean that pertains to you. Doesn't mean you specifically need all of that. And so I take things away and I start and say, we are going to focus on one thing this week. And it might be an exercise. It might be meditation. It might be that they just have to stop with all the things. And one of the things I say about the food, because I always say you need to talk to a sports dietitian, but maybe we won't do it for a week or two so that we can slow down. And how about you just put like something that has the right amount of protein or carbs by your coffee pot, so you don't have to plan your meals for the entire week. You can just grab it and go, so you have some food in your body. So there are a lot of different strategies I think we can use with this patient population. And really this bleeds over to many of our patient populations, is we just sometimes do too much. And doing too much creates so much stress. It increases our cortisol levels and it decreases our ability to sleep and heal.
I couldn't agree more. Yeah.
Sorry,
Well put.
I got on a soapbox. I'm sorry, guys.
I think we all have already.
All right. Well, I think that was a good. Let's wrap this one up, because I think we have a lot to say, but we managed to talk about most of the things. So I think let's go back around and each one of us say the one thing that we want our clients or people listening to this to take from this podcast when we're talking about this patient population and a glute tendinopathy. And why don't we start with you, Kelsey?
Yeah, I think that just going on kind of my theme that bodies are meant to change. The only constant is change. And yeah, I think that just trying to support your body throughout, every change and process it goes through is critical.
Great. Sarah?
Yeah, and actually kind of building on both of you guys, one of the things I was going to say earlier was that the insight piece is just so important. So being able to take a step back and just kind of understand what's happening with your body and being able to work with it. And then just observing how things are working and what is it that we need to focus on, being able to understand when you're tired, what's like true exhaustion and what might be like, oh, I just need a little push to get to that workout. And we have some tools that we can use to do that, but we don't necessarily need to have all the data pieces in the world. So certainly trying to simplify things like you said, Kate.
Good. And mine would be make sure you're treating the right thing. So a lot of times this particular diagnosis is treated as so many other things and it's missed, and especially in this population. So you need to work with someone that understands that in this part of our life, we have a changing hormonal profile and we need to address that in conjunction with typical physical therapy. We can't just let it be something that we're ignoring completely. Great. All right. Well, thank you so much for listening, everybody. I hope you enjoyed this podcast. As always, please follow us. And if you like this podcast, share it with your friends. We are really trying to spread the word, get this out so we can help as many runners and healthcare providers and coaches as possible to really just get good information out there about running. And so please forward it along to your friends. And then if you guys have any questions at all, feel free to email us at runcasemiles@gmail.com. And full disclosure, I check it about once a week, so it might take a few days for me to get to you, but we will definitely be checking it. And if you have cases you want us to go over, then send them our way and we'll do our best to get to them. All right. Thanks, everybody.